Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Autologous and Allogeneic Stem Cell Transplantation for Transformed Follicular Lymphoma, a report of the Canadian Blood and Marrow Transplant Group by Diego Viela and others. My name is Jim Armitage. I'm a professor of medicine at the University of Nebraska Medical Center in Omaha, and my particular interest is the care of people with lymphoma. The transformation of low-grade or indolent B-cell malignancies to a high-grade lymphoma, usually diffuse large B-cell lymphoma, was first described by Maurice Richter, who was a pathologist at Bellevue Hospital in New York City. In 1928, he reported a 46-year-old man admitted to the hospital with pain and weight loss and who subsequently died, and an autopsy was found to have a lymphocytic leukemia and reticulum cell sarcoma. Subsequently, the term Richter syndrome was coined to describe this phenomenon. While most often used for patients with chronic lymphocytic leukemia who develop diffuse large B-cell lymphoma, it is sometimes applied to transformation of other low-grade B-cell lymphomas, including follicular lymphoma. It appears that the risk of transformation to diffuse large B-cell lymphoma is highest in follicular lymphoma among all the indolent B-cell malignancies. In follicular lymphoma, the cumulative incidence of diagnosis of transformation has been estimated to be somewhere from 20% to 50%. Although less information is available, it appears that the incidence observed at autopsy is even higher. For patients with follicular lymphoma, it's important to be clear about what one means by transformation. In particular, this should not be used to describe a change in the grade of follicular lymphoma, but should be reserved for patients who develop diffuse large B-cell lymphoma or, in rare cases, another high-grade B-cell malignancy such as Burkitt lymphoma. It has been known for many years that the prognosis for patients with transformed follicular lymphoma is poor. However, in recent years, the outcome appears to be improving for patients with a follicular lymphoma who develop diffuse large B-cell lymphoma. For example, the group at Stanford shows steady improvement in survival of patients diagnosed with transformation in the 1970s to the early 2000s. Some of this improvement appears to be related to the availability of rituximab over the last 15 years. However, the topic of the manuscript in question here, that is the use of autologous or allogeneic transplantation for patients with transformed follicular lymphoma, could also be having a positive impact on the outcome for these patients. It is important when trying to interpret the results of reported studies in the management of patients with transformed follicular lymphoma to realize that not all of these patients have the same outlook. It seems clear from previous reports and in my personal experience that patients in whom transformation is found at the diagnosis of lymphoma or occurs in patients where the lymphoma was asymptomatic at diagnosis and who were never treated have a much better outlook than when transformation occurs in patients who have been previously treated for follicular lymphoma. Other factors that predict the outcome of treatment include chemotherapy sensitivity of the transformed lymphoma, localized versus extensive disease, and performance status. This report by investigators from the Canadian Blood and Marrow Transplant Group is consistent with previous reports in suggesting that patients who are able to have an autologous or allogeneic transplant are more likely to have a good outcome. For example, in this report, the 5-year progression-free survival was approximately 50%, and the 5-year overall survival approximately 60%. It should be noted that the transplant-related mortality was much higher for allogeneic than autologous transplant, that is 23% versus 5%. but this led to a roughly equivalent overall survival because of a lower relapse rate of the allogeneic transplant patients. However, as might be expected, the patients who underwent allogeneic transplantation were approximately a decade younger than those who had autologous transplantation. These authors also carried out another interesting and provocative analysis. They compared the patients transplanted with either allogeneic or autologous transplant throughout Canada as part of studies of the Canadian Blood and Marrow Transplant Group with a separate cohort of patients treated with chemotherapy and rituximab in British Columbia using the same inclusion and exclusion criteria as was applied to the transplant patients. While they found no significant difference in progression-free or overall survival among patients treated with chemotherapy and rituximab versus those treated with the transplant, survival curves presented in the paper suggest more late events in the patients treated with rituximab and chemotherapy alone that might eventually lead to a poorer long-term outcome. At the present time, the best treatment for patients with transformed follicular lymphoma is not clear, and the same treatment is not likely to be the best for all patients. The patients of whom transformation is apparent at diagnosis or appears in asymptomatic patients who are observed without therapy seem likely to benefit from an anthracycline-containing chemotherapy regimen plus rituximab. Whether these patients should be transplanted is a point for debate, but it appears that the diffuse large B-cell lymphoma might be cured with chemotherapy and rituximab alone. Patients with transformation after previous treatment for follicular lymphoma have a poorer prognosis, and when the disease is chemotherapy sensitive and the patient's well enough to undergo transplant, this has been the standard recommendation in the United States. The choice between allogeneic and autologous transplantation has often been based on the age of the patient and the preferences of the transplant group. This interesting report from Canada suggests that if transplantation is selected as a treatment approach, the net effect is likely to be similar with allogeneic or autologous transplantation, with the higher early mortality rate in the allogeneic patients offset by a higher relapse rate in the autologous patients. The most provocative finding from this paper, however, is that those patients who respond to chemotherapy and rituximab might have a similar survival whether or not they undergo transplantation, at least in the short term. This includes this JCO podcast. Thank you so much for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.